All right, so for talk number 5, we're going to talk about arrhythmias. And so let's go over some basics first. And first, let's talk about why cardiac surgery patients are different. So they tend to have a very high degree of structural heart disease compared to other patient populations, and that means that they have more scar tissue in the ventricles. They have dilated atria, can have hypertrophied ventricles, can have valvulopathies, and so they have all this baseline disease, and then they have a high risk surgery including cardiopulmonary bypass. Then they have a long difficult post-operative recovery in the ICU, and so arrhythmias are very common here, and for that reason prophylactic beta blocker is generally given post-op day 1. So next we're going to talk about the 3 main types of arrhythmias, in the first one being atrial tachycardias. Now, atrial tachycardias, the first thing that we need to know about them is that they generally are preceded by something called ectopy, and ectopy is our extra beats during sinus rhythm that shouldn't be there. So they're usually PACs or PVCs. And when a patient has ectopy, it's a problem because they can be non-perfusing beats, which can lower the blood pressure, and they can also interfere with pacemakers. And so as sinus rhythm accumulates more and more ectopic beats, the heart rate will tend to speed up. You'll start to have runs of AFib, runs of SVT, and then the rhythm can organize into, it can become an organized tachycardia or an organized tachyarrhythmia. And I listed here some of those organized tachyarrhythmias, and I think AFib is by far the most common. And so we'll just keep going about how to manage them. So I'm going to start with the management first, and I will talk about why afterwards. So the first line meds for atrial tachycardias are either amiodarone or beta blocker is first line, and calcium channel blocker DIG and ivabradine are second line. And the treatment is generally guided by hemodynamic stability. So if they're unstable, you're going to amio is generally preferred. If they're stable, beta blockers are generally preferred. I kind of wrote there what I consider stable and unstable. That being said, the thing about whenever a patient has an arrhythmia, you should always look to find the underlying cause. That being said, sometimes the reason why they have the arrhythmia in the first place is because their heart and their body is going under a very stressful situation. So sometimes you can do all that you can to optimize these patients, but sometimes they're just going to have arrhythmias anyway. So that being said, you should always look to correct things like electrolyte abnormalities. So keep the potassium above 4, the magnesium above 2, and the phos above 1. And I kind of wrote some special situations here. Correct a hypo or hypervolemia. You can try to turn down some of the adrenergic drips, but at the same time, just understand that you can optimize everything, and that's okay. And some other special circumstances that I'll just point out before moving on is that patients who have low cardiac index, vasoplegia, or sometimes both, you want to avoid beta blockers and calcium channel blockers because the small amount that those 2 classes of medications lower the cardiac output in a healthy heart is not noticeable, but in these very marginal ICU patients, it will be noticeable. What I've also found is structural heart disease, and patients who have a lot of it tend to benefit more from amiodarone. whereas patients who have less structural heart disease tend to benefit more from beta blockers. I can't prove it. I have no clinical trials. I have no data. But what I'll tell you is that healthier people and healthier hearts tend to do better with beta blockers. And then unhealthy people, unhealthy hearts, previous MIs, conduction system damage, tend to do better with amiodarone. And then finally, SVT is ACLS guidelines. Treat it with adenosine if it's stable, synchronized cardioversion if it's unstable. So to summarize kind of all of this, ectopy is a warning sign of tachyarrhythmia. Try to reverse underlying causes first, but know that even if you do reverse everything, that the arrhythmias can still occur. First line meds are amiodarone and beta blocker based on clinical stability, and then there's special circumstances down here. All right, and then we're going to move on next to ventricular tachyarrhythmias, and the one that most people know and that's talked about is ventricular tachycardia. And so I've separated them into device and non-device. So a non-device, I mean a patient who does not have ECMO Impella or some other type of LVAD. And these patients just follow ACS guidelines, high quality CPR as soon as you can, and then defibrillation ASAP. Some of the meds as you can use during this process, I didn't write in, but I probably should have: amiodarone, and then sodium channel blockers, lidocaine and procainamide, and magnesium if it's torsades. And I also listed mixilotine, AICD, stellate ganglion block, surgical sympathectomy. Feel free to read about these on your own time if you want. They're kind of like these interesting, exotic ways to treat a refractory VTAC. So a non-device VTAC in the ICU is treated just like a VTAC anywhere else. Device VTAC is where it's different. So what I do for this is that I will turn up the flows to keep the map at least 50. Now, once your map is at least 50, you are now perfusing the brain. So now, while this is technically a code situation and it's definitely need a crash cart, definitely need to call a code, but it's not like as critical of a situation as normal VTAC in a patient with only, or a patient who does not have a LVAD or a VA ECMO. And so generally these do better when you load them up with medications first. What I find is that device patients who go into VTAC tend to respond to medications a lot better than those who don't have devices for whatever reason. And oftentimes if you turn up the flows first, then you load them with amio, sodium channel blockers, and MAG, they generally convert out just by that. And if they don't, shocking them afterwards is much more effective with the medications. So the main difference here is that with a non-device, shock first, meds as you can give them, and then with a device, turn up the flows, load them up with meds, shock them last. And you usually don't need a CPR, right? If you can perfuse the brain with the device, a CPR is not necessary. All right, and the last one that we'll go to are bradyarrhythmias. So I separated them into surgical and non-surgical, and I listed surgical first because it's something unique to the CTICU in that when you do surgery on the heart, you can either surgically damage the conduction system, or you can cause inflammation around the conduction system that will temporarily prevent it from working. And so that's why surgeons place epicardial pacing wires. And generally, even if a patient has a junctional rhythm in the 40s or symptomatic bradycardia, generally by post-op day 7, the bradycardia has resolved. If it hasn't, then it's time to talk to a cardiology about placing a pacemaker. And AVRs and septal myectomy tend to be the highest risk for permanent conduction system damage. That being said, the 99% of the time when a patient has bradyarrhythmias in the ICU, it is not a surgical issue. And it can be from hypoxia, acidosis, hypothermia are the most common ones in post-op day 0 when they come fresh out of the OR. Then on post-op day, say 1, 2, 3, 4, 5, you're looking at antiarrhythmic overdoses, especially amiodarone, excess sedation, opioid overdoses, vasovagal reactions. The list is kind of endless. So what I'll say is that before you ask the cardiologists and the surgeons about putting in a pacemaker, you really need to optimize the patient and have a very, very good case that you've done literally everything and the patient's perfectly optimized. So if the patient has a bradyarrhythmia, the first thing obviously is to diagnose and treat the underlying cause, and we went over surgical and non-surgical etiologies. While you're figuring it out, you still need to support the bradycardia, especially if it's symptomatic. And so things that you can do first off is pacing. In the CTICU, the easiest thing to do is just turn on the epicardial pacing wires. You can also do a transvenous pacer or transcutaneous pacing. The other things you can do are start some inotropes. So epinephrine and dopamine will both raise the heart rate, and they're also they're chronotropes and inotropes, and so these will help increase cardiac output while you figure out and correct the underlying cause. You can also, if it's an emergency, you can also add some anticholinergics, so atropine and glycopyrrolate. And lastly, to summarize bradyarrhythmias, the first thing you should do is if you have a symptomatic bradycardia or a bradyarrhythmia, correct all non-surgical causes first and wait around post-op day 7. If the patient's doing great and they still have rhythm issues, then it's time to talk to cardiology and CT surgery about pacemaker. And while in the meantime, you support them with anticholinergics, inotropes, and then pacing.